Hello, everyone. You've joined the Beyond Quality of Care Measures Preventing Cervical. Good afternoon, everyone. You've joined the Beyond Quality of Care Measures Preventing Cervical and Breast Cancer in Health Center Programs webinar. It is 10 a.m. right now, Eastern Time, and we're just going to wait a couple of more minutes to allow people to sign in, and we'll begin shortly. While we wait, we have a brief poll question for you, and I'm going to hand it over to Fide to read that question.
Question is your health center currently working with the local housing agency to provide breast and cervical cancer screening to public housing residents? Select one if yes, no, or I don't know.
So, the student is accredited for everyone will also receive, everyone who does this work will receive we also we have the option of accreditation for physician personality types. What I would use is the people who are registered.
Okay, so far 21% have said yes, 53% said no, and 26% said I don't know.
Okay, great. Thanks, Fide. So hello again. Good morning to you if you're on the East Coast. Good afternoon if you're on the West Coast. My name is Saki Malik Cho, and I'm the Director of Research Policy and Health Promotion at the National Center for Health and Public Housing, and I'll be moderating today's webinar. I'm joined by my colleague, Fide Sandoval, who'll be helping during the Q&A session. We would like to welcome and thank you for attending today's webinar, which is Beyond Quality of Care Measures Preventing Cervical and Breast Cancer in Health Center Programs. We have three really great speakers today, one the American Cancer Society, Zufall Health Center, and San Ysidro Health Center. But before we get into the presentations, I have a few housekeeping items that I would like to address. First, this webinar is being recorded, so we've muted all of your lines. We would like to, however, encourage you to ask questions and make comments through the chat function. We're really fortunate today to have some fantastic speakers, and we'd really like for you to get the most out of their time. During the Q&A session, if you would like to, during the Q&A session, if you would like to verbally ask a question, you can use the raise hand icon, and Fide will unmute your line. And please just state your name first and then ask your question. The recording and the slides and the other resources will be emailed to you after the webinar, and we'll also post this on our website, which is nchph.org. Please also don't forget to answer the post-webinar survey at the end, because your feedback is very important to us. So just in case if you all are not familiar with the National Center for Health and Public Housing, our mission is to strengthen the capacity of federally funded health centers that are located in or immediately accessible to public housing by providing training and technical assistance, research and evaluation, and services to build outreach and collaboration. We are funded by the Bureau of Primary Health Care at the Department of Health and Human Services. However, I should note that the opinions that are expressed here in the presentation are that of the National Center and not of HHS. So as I mentioned, we have some really great speakers with us today, and I'm just going to introduce them. The first is Dr. Debbie Saslow from the American Cancer Society. Dr. Saslow is the Managing Director of HPV and GYN cancers at the American Cancer Society, where she's worked since 1997. She serves as the American Cancer Society's lead for HPV-related cancers, and she directs their HPV vaccination nationwide priority program of work. She also provides strategic direction and leads staff teams that are working on the implementation of HPV-related activities and provides evidence-based guidelines to the organization. She's the one that's responsible for developing and updating American Cancer Society's guidelines, including guidelines for cervical cancer screening and for HPV vaccination. She received her undergraduate degree from Brown University, her PhD from Yale University, and she completed a postdoc at the National Cancer Institute's Laboratory of Pathology and Women's Cancers. So after Dr. Saslow, we'll hear from Kathy Orchin, who's from Zufall Health Center. She is been dedicated to healthcare delivery for over 40 years. She's worked most extensively with limited resource populations in the development and implementation of enhanced health and nutrition services. Currently, she's the Quality Assurance Program Manager for Zufall, which is a federally qualified health center that serves over 38,000 patients in the Northwest region of New Jersey. Her commitment to quality healthcare has spanned from rural Appalachian populations to inner city residents to in America's most challenging economic environment. And then our final speaker will be Alejandrina Arevalo, who's the Director of Patient Engagement from San Isidro Health Center. After earning a degree as a medical doctor with an emphasis in general practice and public health in Mexico, she spent her early career in the community as a medical director for a rural medical clinic and was awarded a health community certification for improving patient engagement and care delivery. Dr. Arevalo's passion for patient empowerment is palpable, and her experience driving value-driven engagement strategies for integrated medical home models is deep and demonstrated in her current role as the Director of Patient Engagement, supporting the alignment of patient navigation and social services, women's health referrals and transitions of care, and care management services. So again, I'd like to thank our speakers for joining us today, and we'll now pass it off to Dr. Saslow.
Sorry, I'm just taking a minute to display the, is that showing the slide now correctly?
If you switch your view to your, yeah, there you go. Switch it to presenter view. There we can see it. There you go.
Is that better?
Yeah.
Okay. So hi everyone, and thanks for having me. I'm going to give you a pretty broad high-level overview of breast and cervical cancer with a focus on screening recommendations. So let's start with how are we doing with screening for breast and cervical cancer? And the answer is okay, but could be a lot better. So the target for breast cancer is 81%. That's our goal from Healthy People for 2020. This was not met as of 2015, and we were at 71.6%, which doesn't look too bad, except that the trend is going in the wrong direction. So screening rates have actually been declining. And the same is true for cervical cancer, where the rate, the target was 93%, the rate was 81.2%, but the rate had been higher 5 years earlier. So we have a little work to do. As far as how screening rates differ by race and ethnicity, so for this shows you both for breast and cervical cancer. For breast cancer, the numbers align fairly well. They're much lower in American Indian and Alaska Native groups, although these are heterogeneous, so in some tribes they may be higher, and also in some parts of the country, whereas in others they'll be lower, and not all tribes are represented in the national number. And then for cervix, the numbers are even more closely aligned between different racial and ethnic groups. But there are still a lot of disparities. You're just not seeing them based on race and ethnicity. More likely you see them on access to care. Education level is a big one. Income, how long someone has been living in the United States, whether English is their first language or not, and other cultural factors. So some of these relate to race and ethnicity, while others are independent of them. So I'll tell you a little bit about breast cancer and then switch over to cervical cancer. Breast cancer is the most common cancer in American women. It's the second deadliest next to lung cancer. And we have over 3.5 million women in America living with breast cancer. The death rates have fallen steadily, particularly for postmenopausal women. We know that there are a lot of risk factors for breast cancer and that there is a lot of evidence supporting this. So when I present to you that some risk factors are strong, whereas others are weaker, what I'm referring to is how much do these factors increase or protect against breast cancer, not how strong is the evidence, because the strength of the evidence for all of these is actually pretty good. But the biggest risk factor for breast cancer is simply getting older. Teenagers and women in their 20s do not get breast cancer unless it's extremely, extremely rare. For elderly women, it's actually quite common. So, of course, being a woman is the most defining factor. Some men do get breast cancer, but 99% of breast cancers are in women. Genetic mutations are not that common, but when somebody does have a gene mutation, that will strongly influence risk for breast cancer. And then there are weaker factors like alcohol, breastfeeding, which is protective, hormone therapy, obesity. Obesity comes into play after menopause. So what do we recommend? We don't recommend breast self-exam or clinical breast exam. We have not recommended these for a number of years, even decades, and that's because the evidence just doesn't show that these are effective ways to find breast cancer early and treat them and then prevent death. So mammography is really the standard. And it gets a little complicated because women in their early 40s are at a little bit lower risk for breast cancer and higher risk for getting a false positive if they do get screened. So screening at this age group is based on informed decision making. It's considered optional, but if women do want to get screened, they should do it every year. Women in their late 40s and early 50s should get an annual mammogram, and starting at age 55, they can switch to every 2 years, or they could keep going with annual. And so again, that's informed decision making based on, some women just detect it no matter what. If I have it, I want to know. I don't care how many biopsies I might have that might not be necessary. Whereas other women might say, if it's not going to be as accurate, I'd rather take that small chance of missing a cancer and not have to deal with a lot of tests that will turn out to be unnecessary. And then for older women, it really depends on health and life expectancy rather than age. So I'm going to show you just quickly a couple of data slides to explain why the American Cancer Society made the switch from 40 and over to really honing in on that 45 to 55 group, and 45 as that age where things change a bit. And that's because women in their late 40s are at very similar breast cancer risk and very similar incidence rate compared to women in their early 50s. It's almost identical. But there is a bigger jump between women in their early 40s and women in their late 40s. And the next slide shows you some similar data, but for breast cancer deaths based on when a woman was diagnosed. So again, women in their late 40s, in their early 50s, in their late 50s, in their early 60s, all have a similar risk, whereas women in their early 40s, that's where the cutoff seems to be. I'll switch now to cervical cancer. So thanks to the success of screening, which actually prevents cervical cancer in addition to detecting it early, the number of cervical cancers in this country is much lower than for breast and some other cancers at 13,000. The number of deaths, a little over 4,000, but we're still detecting hundreds of thousands of precancers every year. And so what happens is a woman goes in, she gets her screening test. If it's abnormal, chances are it's not cancer, it's one of these precancers that's easily treated or removed. And so after a dramatic decline in both incidence and mortality of cervical cancer as women started to get screened regularly decades ago in this country, those rates have pretty much stabled. It is difficult to get the low numbers much lower, and I'll give you some reasons as to why that is. But first, let's talk a little bit about cervical cancer risk factors. There's one cause of almost all cervical cancer, and that's the human papillomavirus. So all of these other risk factors just pale in comparison. A woman who has never had any sexual experience is not going to get an HPV infection and is not going to get cervical cancer. There's a tiny bit of weak evidence that women can get a genital HPV infection by non-penetrative sex, but mostly it's when women start having sex that a few years later they start to get HPV infections and abnormal screening tests. The next most important risk factor is women who don't get screened. So if you don't get screened, you're not going to find a precancer, and if it doesn't go away on its own, it can progress to cancer. Screening is extremely effective at finding these precancers, and then those are effectively removed or treated. So there are only a small group of women who are at higher risk outside of this general, either I haven't been screened or was never exposed to HPV, and that's women with immune problems, so steroids, organ transplants, chemo, HIV infection. Those will increase the risk of cervical cancer, as well as smoking. But again, these pale in comparison to HPV and getting screened. Here are the recommendations for cervical cancer screening. These are from 2012, and as I go through them, I'll point out some updates since then. The American Cancer Society is currently updating our guideline, so I don't know what the recommendations will be, but I do expect that they will change in the next year or so. Screening is recommended to start at age 21 with a Pap test every 3 years. Do not get annual cytology. Do not give annual cytology to your patients. There are very, very, very few women who are in the routine screening category who need more frequent screening. It's only those women who are either HIV positive, and even that's come into question, or have had a recent abnormal test, which is no longer screening, it's surveillance and management. Once a woman turns 30, she should switch over whenever possible to HPV testing. The HPV and Pap test can be given together from the same liquid sample. This is referred to as co-testing, and this is so good and so sensitive that screening intervals should be extended to 5 years. And again, it's so good that the ACS says this is the preferred approach. This I've marked in red because it was the only difference between the ACS along with ACOG, the College of OBGYNs, and 25 other organizations all agreed with this guideline. The only different guideline was the U.S. Preventive Services Task Force at the time, and the only difference between those two sets of guidelines was in the word preferred. So it's also acceptable to get cytology every 3 years, and really that's in there as an access concern. HPV is just proving to be so far superior with or without the Pap test. So the task force recently updated their guideline in 2018. They include as the preferred option HPV testing alone, also called primary testing. And so the ACS is reviewing this as well. The FDA has approved primary testing starting at age 25. The task force has said start at 30. There's just some questions about the trade-offs for women in their late 20s. There's a higher risk of false positives and a lower risk of an advanced precancer that would turn into cancer. At age 65 or over 65, women who have had consistently
Hi, everyone. It sounds like we have lost Dr. Saslow. So we are just going to give her just a second to rejoin, just a minute to rejoin our call. So hold on, and I apologize for the technical issues. So it looks like
now
she's
it's
trying
saying
to
it's
join.
reestablished.
Okay, there we go.
When did
All right,
you
good
lose
to have you
me?
back. We lost you just maybe 30 seconds ago.
Okay, so women who don't have a cervix should not be screened for cervical cancer, and for now, women who've been vaccinated should follow the same guidelines. That will likely change, but hasn't changed yet. Okay, so I already mentioned don't screen people annually. We know it's still being done. It should not be done. It does harm. It does not add benefit. We previously had said don't start with HPV testing before 30, but as I mentioned, people are now looking at 25 for primary testing. It's still a big question of whether it should start at 25 or 30. But as more women are vaccinated and start to be screened, we definitely want to move to HPV testing. Cytology won't be effective in vaccinated women. Women with a history of precancer should continue getting screened, even if it takes them past age 65. And our guideline is for all women except women with a history of cervical cancer, DES exposure in utero. That's a pretty small population now, and women who are immunocompromised. So there are different guidelines for those groups of women. These recommendations are based on 12,000 plus articles that we reviewed in a systematic review. We also did modeling studies. We brought together 25 organizations that all agreed on these recommendations. There were a lot of large studies, and so they're strongly, strongly evidence-based and consensus-based. There is new evidence that has come out and continues to come out on HPV testing alone and on how best to screen women who've been vaccinated. So watch for changes in those guidelines, and we've already seen the task force update its guideline to include HPV testing alone. Wanted to speak just a little bit about some disparities So screening rates are almost identical for African American women and white women, but screening rates are lower in older women who have not previously been screened. So, women who have been previously screened should stop screening at 65, but those who have not accessed screening or benefited from screening do need that. Women without health insurance, women with low levels of education, and recent immigrants. These are the groups with the lowest rates of screening. However, we don't, because screening is going to keep the incidence low because we're preventing cancer by finding and treating precancer. But we do see differences, particularly between Black and white women on the mortality front. So why is that? If Black women are getting screened at least as often as white women and their incidence is pretty similar, why almost double the mortality? And there are several reasons. One is that the diagnosis when they do get screened is likely to be later, so they may be getting more aggressive cancers. This is true in breast cancer as well, as far as stage of diagnosis. There may be a difference in the quality of screening, in time to follow-up and quality of follow-up, as well as just overall differences in biology and screening and socioeconomic status. So it's something to be aware of and careful of, and really vigilant about quality of screening and following up any abnormal results in a timely manner. So here are some take-home messages. Particularly for cervical cancer, focus your efforts on unscreened women. Most women who get cervical cancer in this country and around the world have never been screened or haven't been screened in many, many years. Do not screen too frequently. Screening every 1 year or every 2 year, regardless of the test, leads to more harms and really no benefit. Screening with HPV is preferred, with or without the PAP. It's very safe and it has a lot of advantages. For example, HPV testing detects adenocarcinomas, which have been on the rise, whereas PAP tests are really not good at finding those. And again, these are rigorously scientifically based and broad consensus support. And so on my last slide, I'm just sharing some resources. And when these slides are shared with you, you can click on the links to reach the various areas of the American Cancer Society website or toll-free number. Thank you.
Thank you so much, Dr. Saslow, for giving us an overview of all of the screening recommendations. We are now going to switch to Ms. Kathy Orchin from Zufall, Health Center, to give us her perspective. There we go.
Okay, am I unmuted? Hi, everyone. It's nice that you're all on the call. We just had a really great update, which is really valuable, I think, for where the status of things are for screening. So I'm the Quality Assurance Project Manager at Zufall Health Center. We are a federally qualified health center, and essentially our mission is to provide quality, affordable, culturally competent health care in partners with our patients in the community in Northwest New Jersey. So we live by the 3 A's, which are affordable, accessible, and availability, and to be assured that patients receive care even if there's an issue with if they're uninsured or their insurance isn't satisfying all that they need. So let's see. So we have 6 sites at this time. We're in 6 counties in Northwest New Jersey. We actually have a mobile van as well. We also have dental sites, and we also have a dental van. It gives you an idea of where we serve in areas that are customarily considered underserved or care is not available. These are our 2018 statistics. We seem to think we know we served over 39,000 patients with 141 visits, and you can see the makeup of our population. Half of the folks are still uninsured, 65% are Latino, And then I did give what we have here for the public housing patients that we serve. It's specifically the women and the age groups that we're talking about with cervical and breast cancer screening. So we offer core services in primary care, essentially, and then if people need secondary care, hospitalization, those referrals are taken care of, and we monitor the referrals. But we have pediatrics, adult medicine. Everyone can pretty much see what's on the screen. I don't want to repeat it, but we also have additional services that help support the care that we provide. So it's not just a visit to a doctor or a provider. It's we have case managers, we have support for medications, and we also are involved in outreach programs to special populations and, as I mentioned, dental services and HIV care. So what have we been, how do we approach our cervical cancer mammogram screening? And essentially, these are the highlights of the list of the items that we are attentive to, and we do pretty much monitor clinical guidelines and decision support making tools. All our providers are kept abreast of those, and they're reviewed annually, or if a guideline changes, we'll certainly update it during the year. I will show you, we use ECW, eClinicalWorks, and we have a clinical decision support making tab that I can show you providers can use to highlight what tests when a patient comes in, what are they in need of. So if they're not there for that, like if they come in for a sore throat, they can let the patient know, wait, you need an appointment for an annual exam or cervical cancer screening. We do ongoing patient education. We're including GYN in the physical exam because we recognize that helps access and availability. Once they're here, let's be assured we're doing it completely and not having them necessarily return for a GYN visit. The other thing we've worked to do is to have evening and weekend hours, so we're available to people, not just necessarily during 9 to 5 times. We also have some of our sites are close to the public housing, so it allows patients not to be burdened by transportation or access to the site. I'll also show you, we do send out patient reminders to patients who are due for cervical cancer screening. And also I just want to show that we have a broad array of providers who can do the cervical cancer screening. And we also have a team of outreach workers who are working with public housing, homeless population, HIV. So we're out there in the community. It's just not a matter of people having to knock on our door. We go out and find people and let them know that we're available, and we send up our van in particular locations to also see people. The other thing is we're most fortunate we have family planning grants. So at 3 of our sites, we're offering the lowest cost care that can possibly be available, a sliding fee or no cost at all to some of the patients. So as I mentioned, we have policies and procedures, both one for cervical cancer screening and breast cancer screening. This is just a sample, so you can see how they're composed and how they're reviewed. They're heading off to the board of directors next week after being reviewed by our staff for approval for 2019. This also, we track very closely. This is our QA/PI risk management work plan. So we monitor on a monthly basis how many PAPs have been performed, who's compliant, who isn't compliant. And so we monitor it quite closely, and we do the same with mammograms. We are, this is a requirement, particularly PAP tests, and now we understand that mammograms also will become part of the UDS measures, which are are measures that are reported to the federal government annually for preventative care and chronic care. So we say we put out a goal, we say who's responsible for what and what needs to be done over the year. So this is, I mentioned in eClinical Works, we have this CDSS tab, which allows, when you click on that, this is just a test patient. I blocked out the name, but it will show us, the provider can go in and see, oh, a person's due for the cervical cancer screening. The person's due for the breast cancer. They may be here for something else, but at least they can reinforce, please, you need to make an appointment for these additional screenings. So also, on a monthly basis, I work with a data analyst, and I'm able to pull, we have a Tableau dashboard, and I'm able to pull an Excel spreadsheet that can show me the patients who are non-compliant with receiving cervical cancer screening. So I go ahead and I put this spreadsheet together from a Tableau document, from the Tableau dashboard, and then I off to my data analyst. As you can see, I send him an email and say, oh, here's a list of patients that are due for cervical cancer screening, in the next month or so. And then there are specific requirements in order to put the data in a format to be sent out via email. And so once the data is put into that format, it's sent on to our chief of IT, and he actually sends an email to the women who are non-compliant, very humbly saying, you're due for a cervical cancer screening. We'd like you to make an appointment and come in. And that helps the response rate for women who are due. This is the Tableau document. Is it clicking? Yeah. This is the Tableau document that I mentioned, that I can look on a daily basis whom is compliant and who is not compliant, because when I click on any of these bar graphs, I can get an Excel spreadsheet of whom the women are who are compliant and those who are not. This is the public housing data. As you can see, it's around 67, 68 are compliant, but our actual rate for our total population is 81% from our UDS measure this year, which we're quite proud of, but we also know that we need to do a little bit more work with public housing women. Also, I think I was supposed to talk about mammogram screening, which we take ownership that we're not as high with it as we'd like it to be. We know more efforts have to be made in order to get women to follow up on when they're given the referral for the mammogram. 2 of our sites were fortunate. Out of 6 of the sites, we do have a patient navigator, and we found that in those sites, our rates are higher with mammogram screening when there is a patient navigator who is calling the woman and saying, did you make your appointment? Are you going to your appointment? When is your appointment? So the other item that we have that is quite valuable is it's the New Jersey Cancer Education and Early Detection. It's called NJ-SEED, and we have these funds available to help educate people for their cancer screening. So therefore, if a woman says, well, I don't have insurance, I can't have this test done, we link her with the case management that makes the arrangements for the test to be done and the test to be paid for, and therefore that barrier of resources is reduced for her to be able to get care. That's pretty much about it. Thank you so much. Oh, here are materials that we do for marketing and allowing people to know about NJ-SEED and what's available to them. I'll just review what we went over.
Oh, okay.
Thank you.
Thank you so much. Yeah, that was an excellent presentation, and it sounds like you provide such a really comprehensive approach to this care. So thank you for your presentation. And now we are going to hear from Dr. Alejandrina Arevalo.
Hello, good morning. Can you hear me well?
Yes, we can hear you. Thank you.
And can you see my screen?
Yes.
Okay. So I'm the Director of Patient Engagement with San Isidro Health. With me is the manager of the Women's Health Program here at San Isidro, just in case you have questions that she might be able to answer better than me, because she's the one that knows the program inside out. Just a little bit about San Isidro and who we are. We are also an HQHC, a federal qualified health center. Our mission is to improve the health and well-being of the communities we serve with access for all. We just celebrated our 50th anniversary. We provide care for about 97,000 patients throughout San Diego County. We have 15 clinics, 34 program sites. We provide a wide range of services we're going to see a little bit further on. And we follow the patient-centered medical home for the care that we provide. Here is just a little view of the clinics that we have. We have it like you see throughout the South Bay. And we also have a clinic in El Cajon that serves mostly Chaldean and Middle Eastern community. These are the services that we provide. We have medical, behavioral health, dental. We have a specialty. We have HIV, chiro. We do, like I said, follow the PCMH standard. So we try to provide a whole care. The patient is the center, and then everything else follows through. We do case management, outreach. We have health educators. We connect the people to the WIC program if appropriate. More than 90% of our patients are below the federal poverty level. We have 40% children, and we also have more than 20% seniors. So we do have a senior clinic per se. It's not that the clinic is specifically only for seniors, but we do see seniors mostly at that clinic. We also have the PACE program, which is also geared to individuals 55 and older. Specifically regarding our cancer detection program, within the Women's Health Department, we have two different sub-departments. One serves cancer detection program, which has the mammograms and the pap smears, and the other one serves our pregnant women that follows the CPSP standards and guidelines, which is Comprehensive Prenatal Services Program. So we are going to talk about the cancer detection program. Here, it's also called Every Woman Counts. We try to say cancer detection because, you know, some males can have breast cancer, but the program itself is called Every Woman Counts. And what we want to achieve is obviously reduce mortality from breast and cervical cancer among low-income women and be able to provide the resources they need if they encounter this illness. To be eligible for the Every Woman Counts program, the CDP must certify that the patient is uninsured or underinsured based on self-report. So in the community that we live, we are at the border. We have a lot of migration back and forward from Tijuana and San Diego. A lot of the patients that we serve, many of them, even though they're residents, they live in Tijuana and they just come to the U.S. to receive medical services. So sometimes it's a little challenging to be able to certify who's underinsured, who's uninsured, who's not eligible for the services. But for this particular program, it's based on self-report. Okay, so then what do we do as strategies to engage patients? We do mammogram events per site. Like I said, we have several different sites. We have partnered with an organization that has mobile mammograms machines. So what we do, we create this whole event. There's a lot of preparation before the event. Case managers are calling patients, patient navigators are taking calls, call center making calls, so we can have a full day of mammograms in the clinics so we can make it convenient for the patient. We also do after hours pap smear events where physicians will stay, let's say, from 6 p.m. to 8:30 p.m. just doing pap smears to make it convenient for all of the women that work. And then we also do Saturdays. So we have some clinics open on Saturdays, but we do events specifically on a Saturday, so then we can cater to those that are constantly working and cannot come during business hours. We also give incentives. We give gift cards. We have a little hygiene kit that is super cute. It's a little pouch and has feminine products, and the patients actually like it a lot. They come, they do their pop, and we give them the little hygiene kit. We also do outreach. We do phone, mail, and we also do health fairs. And at the health fairs, we try to provide as much information as we can for those patients that might be, the medical home might be San Isidro, but they don't usually come to us because what I said about the back and forth with the border. So they can come to us and we can feel the measure and be sure that all these activities are done. For 2018, the numbers that we have, we completed 8,785 mammograms. From those, 2,700 were abnormal, and we had 31 diagnoses of breast cancer. All of these patients are followed through with their own case manager. So when a patient comes to the CDP program, they have a case manager assigned, and that case manager will take them through the whole process. We do partner with the CFB and Scripps for this program and for the diagnosis and treatment. And the case manager has relationship with those, so the patient is guided and has a point of contact through the whole process. For what we have for 2019 so far, we have the number of patients, we have 3,000 that are not in the program, 400 and plus that are in the program, and you can see the diagnosis that we had so far for this year for actually cancer diagnosis. And for cervical cancer, we have 60,000 that we did abnormal. This is good because the abnormal results is not very high. We only have 8 compared to the 16,000 that we did, which is good. And again, these patients have somebody to guide them through the whole process with their case manager. For cervical cancer screening, we have so far for 2019, 1,800. 223 are in the program right now. So far, we had 4 diagnoses for patients that are not in the program and no diagnosis for patients in the program. And again, those patients that have the diagnosis, even though they're not in the program, they will still have guidance and they will still have a point of contact, even though they're not specifically in the program. The case manager will still help them, and we provide, there's a big folder with resources that has like the whole process, and it also helps for them to keep track of their appointments, keep track of their diagnosis, imaging results, everything that is needed. It's part of that binder. So the challenges that we have, like I said, we are a border community. So the biggest challenge is patients that are last to follow up. We have many patients that we contact, they say, yes, we're gonna go. They don't come, there's no show, and then we cannot contact them again. The same, we have patients that are assigned to us. However, the phone number is not working anymore, or somebody picks up and says, no, they're living in Tijuana now. That's one of our biggest challenges. And the second challenge is the non-compliant patients, as you know, those patients that don't come for mammograms, or they come for a mammogram, there's an abnormal result, and we cannot get a hold of them for follow-up. Those are the biggest challenges. What we try to do for this, first we have for the first challenge, last to follow up, we try, like I said, the health fairs, because that way we know in here word of mouth is very big. When we do health fairs, we start seeing patients that say, oh yeah, I was called, but I couldn't come, so we try to catch them at that time. We also try to do a lot of phone calls, letters, and then start getting phone numbers, alternative phone numbers from others, such as the EHR, or if we have family members, just try to get another phone number for the patient. And then the best practices. What works for us is a team-based approach. The CDP case manager is basically the person that is guiding and supporting everything. But then we have the clinic managers, because they help with all the coordination for when we have events. Then we have patient navigators. The patient navigators will call the patient or take calls from the patient and steer to the right direction. We have the medical assistants for preparation of the paps or for prepping also for the mammogram. We have referral specialists, because when a patient needs a specialty referral, they come into play. And then obviously the providers supporting the program and supporting doing all these events. And this picture that you see is actually from one of our events in one of our clinics. We also have a lot, like I said, patient education and promotion. We have flyers, we have events, we have the providers are really, really supportive of the program. They try to let our patients know the importance of this preventive screening. And again, phone, mail, and letters. And then I would like to end with a success story. This patient was diagnosed with breast cancer in 2017. And she said she actually came because one of the case managers called her, and she agreed to the mammogram. She came, and that led to a cancer diagnosis. And she told us, if she would not call me, maybe I wouldn't be here, or my life would be totally different. So that's what we wanna, take with us. Like, yes, it's a lot of work. Yes, there's patients that are not compliant, but then we do have the satisfaction to see that because of that work, we could save a life. And that's it.
Thank you so much. What a great way to end with on such a positive note. So now it's time for our Q&A session. Fide, can you switch so that we can see the instructions on my screen? Thank you. So again, if you have a question, please submit it through the question box on your control panel. And if you are dialed in through your telephone and you'd like to verbally ask the presenter a question, you can use the raise hand icon, and your line will be unmuted. So I'm going to ask Fide to let us know if there are any questions in the chat or if there are anyone with a hand raised.
So far we have one hand raised by Juani Gomez Coria. I'm gonna go ahead and unmute him or her. Juani, can you hear?
I'm sorry. Yes, but that question was for earlier when I was not able to hear the presenter. So that was earlier. I don't have any questions at this moment. Thank you.
Okay.
Okay, while we're waiting for people to submit their questions in the chat, I do have one question, which Ale had mentioned, which is one of the major challenges is the delay or in the loss to follow-up. I was wondering, do either one of you guys in your patient reminders use text messaging or use the patient portal for reminders? I know that you mentioned making phone calls, but I was also wondering if you did text messaging or any other kind of patient reminder.
this is Alejandrina. We do, if we have on file an email and if we have on file the permission to text, then we do. We do send emails and we do send texts. Not to all the patients because we get permission for the text, and the emails, obviously sometimes it's really hard to get emails from all the patients. That could be a challenge, but we use it, yes.
Do you are able to send text messages in different languages?
So we do English and Spanish.
Great. Fide, do we have any other questions from the audience?
Yes, so we have two more. One we have from Alice Brown. Her question is, please define what harm comes from yearly cervical cancer screening / HPV testing.
Sure. So hi, it's Debbie Saslow. The main harm of screening is false positives. And so if you, for any question about screening, whether it's how often, which test, you look at what are the benefits and what are the harms, and you have to define those. So the benefit would be detecting cancer early, detecting advanced precancer. The harm, the real harm is downstream side effects of overscreening and false positives. So, for example, multiple biopsies, particularly in young women, can lead to a cervix that won't hold a pregnancy to term. There's low birth weight babies. There's some bleeding. There's anxiety, financial costs, time away from work. Now, most of these are not measured in a typical scientific journal article, but before any of those harms can happen, the next or first test would be a colposcopy, and then usually accompanied by a biopsy. And so most papers do report the number of colposcopies, and for any increase in detection of an advanced precancer, for one case detected, the sort of acceptable trade-off has been 10 additional colposcopies, and then, you know, something like annual screening, it's far more than that. The equivalent for breast cancer screening would be if you screened all women with an MRI instead of just those at highest risk, because an MRI will find more cancers than a mammogram, but it will find a whole lot of things that are not cancer, and you'll have a lot of women, a lot more women that already are getting biopsies that are not cancer getting them.
Okay, so we have another question from Barbara Fargo. How are you able to offer monetary incentives for patients who have screenings completed without it being a compliance issue?
Kathy or Ale, would you like to handle that question?
We don't offer any incentives.
Hello? So you're asking how can we provide, like, for example, a gift card for a patient that completes a PAP? Is that the question, without it in compliance?
Yes, let me repeat it again. How are you able to offer monetary incentives for patients who have screenings completed without it being a compliance issue?
Yeah, so what we do, the insurance company, for example, let's say the patients are assigned a specific insurance, they will provide incentives for us as San Isidro, and then we basically reach out to the patient and give that patient that incentive. we have a list. For example, each health plan will provide us a list that says, from all the PAPs that you've done, this patient are still not completed. So we start reaching like intensively to those specific patients that have been non-compliant, and we are able to provide like a gift card after they complete the assessment. And we do at least 3 attempts to reach that patient. We have not incurred in any compliance issue in terms of an organization.
Okay, great. Thank you so much. So we've reached the end of our time. I'd like to ask attendees to just insert your question in the chat area if you already haven't, and if you have a burning question, and we can respond to those questions via our follow-up email to you in case you want to do it that way, since we've reached the end of our time. I would like to thank all of our speakers today for presenting this morning, and I would like to remind you all that we provide a number of resources at nchph.org that may be helpful to you, including learning collaboratives, and we have an upcoming learning collaborative on diabetes management and prevention, as well as cervical cancer, which you might be interested in. In order to get that information, you can join our mailing list and receive all of these updates, including funding opportunities. You can follow us on social media through Twitter, Facebook, or YouTube to get updates, or contact any of the staff directly for any training and technical assistance or support. So thank you again to everyone for joining today, and have a great rest of the day. Thank you.